Hi and welcome. Let us go through this hematology and endocrinology question set together. So the first question goes on to say, in which condition is serum calcium high, phosphate high, and parathyroid hormone suppressed? The most definite answer is C, milk-Alkali syndrome. But first, let's look at all the other options and understand why they're not correct. So the primary hyperparathyroidism is not correct because, firstly, the parathyroid hormone we know is responsible for regulating the calcium and phosphate levels in the blood. So parathyroid hormone is responsible for increasing the calcium level and decreasing the level of phosphate in the blood. So it increases the calcium in the blood by encouraging kidney reabsorption as well as bone resorption, as well as encouraging intestinal absorption through vitamin D. So the phosphate levels are mainly reduced in the blood by inhibiting, the parathyroid hormone does inhibit kidney reabsorption of phosphate. So through the process of feedback, when the calcium level is high, then the parathyroid hormone released into the bloodstream is going to be low. But when the calcium level decreases significantly, the level of parathyroid hormone in the blood increases because the parathyroid gland produces a lot of parathyroid hormone in order to increase the calcium level. The same also goes for phosphate. So in this case, the first option, primary hyperparathyroidism. Hyper would mean that the level of PTH in the blood is high, which is the opposite of what the question says. Now, this is the main exact reason why option A is not the correct answer. Now, vitamin D intoxication is also not the answer because in vitamin D intoxication, in these ones, they usually would be an association of granulomatous diseases, such as, for example, sarcoidosis. Because, okay, fine, let me explain this. Because the macrophages, granulomatous, so the macrophages that are produced in these granulomas tend to increase or produce vitamin D. So this vitamin D then increases the absorption, intestinal absorption rather, of both calcium and phosphate. So in this case, we are bound to see both a high level of calcium and high phosphate levels, which, yes, up to this level, it matches with the question. So now it's about to get interesting. For this particular option, if it was to be the answer, granulomatous, usually there would be other clues that involve granulomatous diseases. For example, lung involvement and high ACE, etc. So also vitamin D levels usually are very high and are usually measured to confirm vitamin D intoxication. So familial hypocalciuric hypercalcemia. So hypocalciuric hypercalcemia. So this one is mostly associated with, or it is mainly due to genetic mutations. So this is whereby the calcium, there is a mutation in the calcium sensing receptors in both the parathyroid gland and the kidneys. So a mutation in the parathyroid gland enables it, or it enables it to be able to sense the level of calcium in the blood. So the parathyroid gland thinks that the calcium level is low because it is not able to sense or detect the calcium level at the blood. What happens as a result? There is an inappropriately high level of PTH being released. It would not be suppressed, as the question says. And then secondly, the kidney also has defective receptors. Kidneys also are not able to sense the level of calcium in the blood. The kidneys think that the calcium level is low and there would be an overall increased reabsorption of calcium by the kidney. So increased reabsorption means what? Low urine calcium, which is a key distinguishing feature for option D. So also in this case, the phosphate levels here are usually normal. So why does option D fail? Because, like I said, the parathyroid hormone is not suppressed in this case. It is usually high, slightly elevated, or mildly elevated. So now let's go to option C, the correct answer. Why is it that we have the milk alkali syndrome? So in this case, the milk alkali syndrome is caused by excessive intake of calcium and absorbable alkali. So this is classically calcium carbonate plus milk. But nowadays, it's mostly associated with calcium supplements and antacids for osteoporosis or GERD. So this massive calcium load overwhelms renal excretion. So alkali load causes metabolic alkalosis. So this metabolic alkalosis increases renal calcium reabsorption. So what happens here? We are going to be having a hypercalcemia, direct suppression of PTH. So the phosphate in this case remains normal or high because, yes, let's look at the first reason. It remains normal or high because, one, PTH is suppressed. When PTH is suppressed, it means no phosphaturia because nothing inhibits, like I said, nothing inhibits the kidney to reabsorb phosphate. And also alkalosis that comes with absorbable alkali or metabolic alkalosis caused by this alkali encourages or rather promotes phosphate retention. Hence why we experience or we get to see an increased level of phosphate or slightly elevated. I hope you understood that. Now let's take a look at the second question. A 45-year-old man with newly diagnosed type 2 diabetes has an HbA1c, the marker 9.8%. He's obese and has non-alcoholic fatty liver disease. Now, which drug is most appropriate? First line. Now, the most definite answer is B, followed by C. C could quite possibly be the answer, but the best answer is B. Now, in this case, what are we looking for? There is obesity, and there is also a non-alcoholic fatty liver disease. So this is a patient profile analysis. So in this case, with a very high HbA1c of 9.8, we need a strong glycemic efficacy, which also has a rapid effect. The patient is obese. We need to be able to initiate weight loss. Non-alcoholic fatty liver disease, whatever drug that we are to settle for, that it should have a proven benefit on liver fat, inflammation, and fibrosis. So now looking at all of these, metformin to start with. So metformin is still a very good option, but not the most appropriate first line here. Why? Because metformin does not have a strong benefit on the non-alcoholic fatty liver disease histology as compared to B and C. And also weight loss, there is weight loss, but it is modest, and also GI side effects that come with metformin could be problematic in obese patients. So it doesn't satisfy any of, this is our first criteria, second criteria, third criteria. It doesn't satisfy any of this. So let's go to the last option, D. Yeah. So this one, it's good for non-alcoholic fatty liver disease, but has significant drawbacks and also causes weight gain. So it goes against our third criterion and also comes with fluid retention and edema. These are some of the drawbacks that I already mentioned. So there is a risk of heart failure exacerbation also. Weight gain as well as risk of blood fractures is what won't allow us to settle for the last option. So let us look at option B, the sodium glucose co-transporter 2 inhibitors. They work through, the mechanism is that they reduce the glucose level through urine. And then the option C, glucagon-like peptide 1 receptor agonist. These includes drugs such as Ozempic that mimic insulin and also reduces appetite. So the first option B is co-transporter 2 inhibitors. One, they have a good HbA1c reduction. And they also reduce weight loss. That fits the second criterion. And also they have an excellent NAFLD benefit. That is, it reduces liver fat and also improve ALT. Remember, that's one of the markers for the liver function. And also there's some profound evidence of fibrosis regeneration. So looking at C, it has a superior weight loss. And also it has a very strong NAFLD benefit. There is a histological improvement in continued trials. So which is why we would settle for B followed by C. I hope that was clear.